So much of that today, and tremendous progress, which is really what this is about, and what these oral abstracts actually that you're going to hear about are about: moving things forward, making things better for our patients. So thank you for coming. My name is Dan Geinesman from Fox Chase Cancer Center. We had about 78 or 80 abstracts submitted. There was a scientific review, and there were 4 oral presentations that you're going to hear. There are also 2 top-rated posters that you guys can see in the poster session. One by Dr. Abdallah, which is comparing the post-operative glomerular filtration rate prediction accuracy of a fully automated AI-generated and a validated clinical model in patients with renal masses. And then one by Dr. Hayes, looking at spatial analysis of immune cells and tumor immune cells in the microenvironment and papillary renal cell carcinoma. So please visit those. And I think without further ado, let's begin. So Dr. Paul is first, and he's going to talk about zanzalintinib in clear cell RCC, results from Stellar 001.
Great. Well, thanks so much, Dan. Appreciate that introduction. And on behalf of my co-investigators, I'd like to thank the Kidney Cancer Association for the opportunity to present to you this novel data set. Just wait a second here for my slides to pop up. All right. Should be up any minute now here. There we go. Oh, nope, not yet. Not yet. Let's take a look here. You know any good jokes, Dan?
Not ones you want to hear.
Okay. There we go. Well, again, on behalf of my co-investigators, I'm honored to present to you the results of zanzalintinib in clear cell renal cell carcinoma, results from the Stellar 001 study. Today, our learning objectives include understanding the preliminary efficacy of single-agent zanzalintinib, including by prior exposure to tyrosine kinase inhibitors in patients with previously treated advanced renal cell carcinoma, included in an expansion cohort of the phase 1 Stellar 001 study. I'll also describe to you the safety of single-agent zanzalintinib within this cohort and in a larger safety population of patients with advanced solid tumors. It's well known to this audience that VEGF TKIs, including cabozantinib, really represent a cornerstone of therapy for advanced renal cell carcinoma. Zanzalintinib is a novel, multi-targeted TKI that inhibits kinases including VEGF receptor, MET, and the TAM kinases, including TYRO3, AXL, and MER. And we hypothesize that because of its short half-life, it may have improved tolerability. VEGF receptor, MET, and TAM kinases are involved in tumor growth, angiogenesis, and in immunosuppression within the tumor microenvironment. And we believe that targeting MET and the TAM kinases, in addition to VEGF receptor, may potentially prevent resistance to VEGF receptor inhibition. Herein, we present preliminary efficacy and safety results for single-agent zanzalintinib in clear cell renal cell carcinoma. Our study was described as follows. We had a single-agent dose escalation cohort, including 49 patients with advanced solid tumors. Patients within this cohort were dosed with zanzalintinib in the range of 10 milligrams to 140 milligrams daily. We ultimately arrived at a recommended dose of zanzalintinib of 100 milligrams oral daily. We then shifted focus to a clear cell renal cell carcinoma expansion cohort, including 32 patients with advanced metastatic or recurrent RCC with clear cell histology. We did permit sarcomatoid features. Patients had to have had measurable disease. They had to have an ECOG performance status of 0 or 1, and they had to have received 1 to 3 prior systemic anti-cancer therapies. The primary endpoint within this particular expansion cohort was objective response rate and progression-free survival at 6 months. Secondary endpoints included safety, and exploratory endpoints included progression-free survival, duration of response, and overall survival. Notably, here we present safety data for a population that includes both the dose escalation cohorts as well as the clear cell renal cell carcinoma expansion cohort. I wanted to highlight some of the patient characteristics. You'll note that age and gender distribution is typical for a renal cell carcinoma population. About 80% of patients included this experience had intermediate risk. But I'll point out that the patient characteristics here really suggest a bit of an aggressive phenotype within this cohort. 38% and 34% of patients included in this cohort had liver and bone metastases. About 41% of patients had received 3 prior lines of therapy. Virtually everyone in this cohort had received prior immune checkpoint inhibitors. 81% had received prior VEGF TKIs, and more than half had received prior therapy with cabozantinib. Seen here is the best response to zanzalintinib. I was impressed to see the objective response rate of 38% in this cohort, with many patients, again, with this sort of aggressive overall phenotype, achieving very deep responses to therapy. The disease control rate was 88%. Shown on the right-hand side is response based on receipt of prior cabozantinib. If we include those patients that had specifically received prior cabozantinib, response rate was 24%, and disease control rate was 94%. Very few patients in this experience with primary progressive disease. And if we exclude patients receiving prior cabozantinib, that response rate actually rises to 57%, with a disease control rate of 86%. If we focus specifically on about the 80% of patients that had received prior VEGF TKIs, you can see that if we include cabozantinib, the response rate is 35% with a disease control rate of 92%. And impressively, exclude cabozantinib, amongst those patients that had received prior VEGF TKIs, the response rate was 63%, and all patients achieved disease control. Importantly, 3 of the 4 cabo-exposed patients who responded to zanzalintinib had actually discontinued prior cabozantinib on account of prior disease progression on cabo. Shown here are many durable responses to zanzalintinib. If we focus on the cabozantinib naive cohort, shown with the black arrows are patients with ongoing therapy with zanzalintinib, and you can see that the median duration of response was 7.4 months, with many patients with ongoing responses. The same is true for the cabo-exposed population, where the median duration of response still hasn't yet been achieved. At a median follow-up of 8.3 months, 50% of patients were ongoing on treatment, and 75% of responses occurred at the first post-baseline tumor assessment, including all responders who had prior cabozantinib therapy. Here's the safety summary from this study. Importantly, in both the clear cell renal cell carcinoma population and the safety population, median exposure is quite similar, 6.4 and 6.8 months respectively. We encountered no grade 4 or grade 5 treatment-related adverse events with zanzalintinib, nor did we encounter that in the safety population. Dose modifications occurred in 56% and 84% in the zanzalintinib population, and you can see discontinuation rates listed there at 9% for treatment-related adverse events. As we shift focus to the right-hand side, one of the things I'll point out is that the rates of diarrhea, hypertension, asthenia, side effects that we've become accustomed to amongst TKI strategies appear to be a bit lower with zanzalintinib, particularly with respect to grade 3-4 side effects. And in particular, the rates of stomatitis and hand-foot syndrome, in my opinion, were particularly low. And that's highlighted at the bottom of this tornado plot. So in conclusion, single-agent zanzalintinib demonstrated promising anti-tumor activity in patients with heavily pretreated advanced clear cell renal cell carcinoma, really irrespective of prior treatment with cabozantinib, with an objective response rate of 38% in the overall clear cell RCC cohort. Anti-tumor activity was observed in patients who had progressed on prior VEGF TKIs, including cabozantinib, really suggesting that zanzalintinib may be able to overcome resistance to prior VEGF receptor inhibition. I'll point out again here that the objective response rate was 57% in patients that were cabozantinib naive. Zanzalintinib appears to be generally well tolerated in this heavily pretreated VEGF TKI prior receipt population, and the safety profile of single-agent zanzalintinib in the clear cell RCC cohort seemed to be very similar to the larger safety population. The rates of hand-foot syndrome and stomatitis, as I already highlighted, really appear to be relatively low compared to the rates that we encounter with other VEGF TKIs. So what does this mean for practice on Monday? Well, in Stellar 001, we saw that zanzalintinib had significant anti-tumor activity in patients with heavily pretreated disease. I think there's a certain uniqueness to this amongst the existing landscape of VEGF TKIs with respect to both clinical activity, with the response rates that we're seeing with subsequent use in advanced patients, and also with respect to the safety profile of the therapy. Zanzalintinib is also being evaluated in different combinations with immune checkpoint inhibitors in both the first and second line setting, and also in a phase 3 clinical trial in combination with nivolumab in patients with previously untreated non-clear cell renal cell carcinoma. The Stellar 304 study is being highlighted in the poster session next door, and I encourage you all to check out our trials in progress there. I'd first and foremost like to thank the patients and their families who participated in this study. And if you'd like to learn more about the Stellar 01 experience or Stellar 304, as I just alluded to, you either use these QR codes or we're happy to answer questions during the poster session next door. Thank you.
Great, thank you. Next, Dr. Otaki will talk about models of neurofibromatosis loss and hereditary HLRCC kidney cancer.
Thank you. Hi, my name is Shinjo Take, and it's very great honor for me to be chosen for this award. And I'm glad to have a chance to tell you about some of our recent work on the role of NF2 gene, which is considered to be an important factor in the hereditary rheumatosis and renal cell carcinoma kidney cancer. Learning objective treatment option for HRCC with NF2 deficient. First, some background. Humic hydrate, FH, is a citric acid cycle enzyme. There's a syndrome named hereditary rheumatosis and renal cell carcinoma, and result from germline mutation in FH gene. It's an autosomal dominant manner and have some specific tumors, including RCC. And viral inactivation of FH gene leads to loss of FH protein expression and function, alternation in oxidative carbon metabolism, switch to aerobic glycolysis, etc. And FH mutation also alters tumor cell migratory potential, response to oxidative stress, and response to DNA damages. These changes lead to very aggressive biological behavior and often metastasized at the time of diagnosis. But we don't have good treatment option for these symptoms. Next, I explain about neurofibromatosis type 2. NF2 is caused by germline mutation in the NF2 gene, and it's inherited in an autosomal dominant manner. Patients with this gene alternation have tumors on the nervous system, and it leads to some specific syndromes: hearing loss, balance problems, and weakness. Many cancers, including RCC, have this NF2 gene mutation. So, how is its frequency? And this is data from 2020 Genitourinary Cancer Symposium. NF2 gene alternation frequency was low in CCRCC. It's only 3%, but for non-RCC, the frequency is 13% to 20%. And next, how about NF2 mutation in FH deficient RCC? They are so rare that there are not so many reports, but these papers are mentioned about such tumors. In total, 9 in 62 patients with FH deficient RCC have pathogenic NF2 gene. It accounts for 15% and one of the highest co-occurring gene mutation. So NF2 mutation is common in patients with this subtype, but we still know very little about the role of NF2 mutation. In our study, we decided to focus on NF2 loss of function in FH deficient RCC. To examine, we knocked out NF2 into FH deficient RCC patient derived cell line, and then analyzed its effect on their behavior. We used these 3 cell lines, and CCH1, UK262, and UK268. The 3 isogenic NF2 knockout cell lines were generated using CRISPR. We transfected NF2 knockout plasmid into these cell lines and empty vector as control. And this is a figure Western blot confirming CRISPR-mediated knockout of NF2. Next, we checked gene expression. Gene expression changes were evaluated using nCounter tumor signaling panel. There's a clear difference with 70 genes upregulated and 20 downregulated. With annotation gene set analysis, these pathways, including mTOR signaling, had a high significance score. And using these cell lines to confirm their characteristics, we performed these assays. A, B, and C indicate each cell lines, and it means that NF2 knockout in each cell line have significant difference compared to control. For example, in wound healing assay, NF2 knockout accelerated wound closure in all cell lines. And in transfer invasion assay, NF2 knockout led to significant increase in cell invasion activity in NSCCFH1 and UK268. Together, this result indicates that NF2 knockout cell lines have more aggressive behavior than control. Next, we wanted to know whether drugs targeting NF2 altered tumors is effective to these models. So we performed chronogenic survival assay with some drugs, like rapamycin and everolimus as mTORC1 inhibitor, and brigatinib as mTORC1 inhibitor, and others. In those drugs, rapamycin was most effective. This is a result of a chronogenic survival assay with treatment of rapamycin. In NCCFH1 and UK262, treatment of rapamycin significantly decreased colony number and area in NF2 knockout. Based on chronogenic assay result, we next assess the effect of rapamycin on cell growth and invasion. This is the result. Treatment of rapamycin in NCCFH1 and UK262 significantly decreased their growth. In invasion assay, rapamycin suppressed all cell line invasion. In short, our study has revealed that rapamycin is an effective drug for FH-deficient RCC with NF2 knockout cell lines. As next step, we will treat mice xenograft with rapamycin and see if its effect in vivo. And we will create transgenic mice model with FH and NF2 double knockout. And take-home message, we sometimes have problem with treatment plan for patients with HRCC kidney cancer. At that time, tumor profiling may be variable in such patients for NF2 mutation. As mTOR inhibitors are already approved in RCC, these agents may be considered for NF2 deficient HRCC tumors that are treatment refractory. Thank you.
Thank you. Great. Let's just keep moving on. Dr. Glennon, germline susceptibility in renal cell carcinoma and implications for genetic screening.
Thank you. Perfect. Okay, thank you for having me today. It's an honor to be here. The learning objectives for my talk is first to investigate susceptibility to sporadic RCC within Canada, and also compare global differences in germline susceptibility to RCC, and finally to evaluate the performance of referral criteria for genetic screening overall. So, though the genetic factors involved in syndromic RCC are well established, the factors that predispose for sporadic disease are not very well understood. Syndromic cases are typically characterized by known renal cancer genes, but only make up 5 to 8% of RCC cases. The genetic factors that predispose for sporadic disease are just recently being studied, and rather than being limited to renal cancer genes, predisposition genes likely also include non-RCC specific genes. Additionally, there are also large unexplained variations in incidence of RCC across the globe. And to further understand these differences, we need large-scale studies investigating susceptibility to RCC among different populations. So as of yet, there have been no studies within Canada, so we were motivated to investigate germline susceptibility to RCC within the Canadian population. This can not only help us to investigate both the individual risk of developing RCC, but also contribute to our understanding of the global differences in RCC incidence. A few large-scale studies have investigated pathogenic germline variants in RCC, including one published by some of my co-authors in Japan last year, and they investigated germline mutations in RCC within the Japanese population, investigating both traditional cancer susceptibility genes and RCC-related susceptibility genes. They found here that within clear cell RCC, the most frequently mutated gene was TP53, while in non-clear cell RCCs, they found BAP1 and FH were the most frequently mutated. Another study published last year investigated germline mutations within a European cohort, where they found the most frequently mutated genes to be CHEK2, MITF, and ATM. So these two studies alone show the stark differences in which genes may predispose to RCC just within two populations. To investigate germline susceptibility to RCC within the Canadian population, we were able to collect germline DNA from just under 1,000 patients through the Ontario Tumor Biobank. And this cohort is made up of mostly clear cell RCCs, but there's also a decent number of non-clear cell subtypes, which allows us to investigate differences in predisposition genes between subtypes of RCC. To identify pathogenic variants, germline variants present within this cohort, we used a multiplex PCR-based targeted sequencing method. And this method involves 2 PCR steps, the first with custom primer pools for targeted gene panels, and the second to add dual barcodes. We used 2 separate gene panels here, one targeting general cancer susceptibility genes and another targeting RCC-related genes. Overall, we targeted 19 RCC genes and 27 cancer susceptibility genes. We next sequenced the PCR products, used our bioinformatic pipeline to identify pathogenic variants and loss of function variants within the cohort. So here we included variants that were listed as pathogenic or likely pathogenic within the ClinVar database, along with those with predicted high impact loss of function effects. And overall, we identified 39 variants as pathogenic or as loss of function, with 5.8% of patients having a pathogenic germline variant in the cohort. And this frequency is really similar to other large studies when it comes to the proportion of patients with mutations, but the individual genes contributing to them are different. Within our Canadian cohort, the most commonly mutated genes were CHEK2 and MITF. And we did also notice some patterns in the distribution of variants within the cohort, so especially with regards to subtype. This oncoplot that I'm showing here is split a few different ways. On the left side, we have the clear cell subtype and the non-clear cell on the right side. Additionally, genes are grouped based on whether they are a general cancer susceptibility gene up on the top or an RCC-related susceptibility gene on the bottom. Within the clear cell subtype, most mutations were within general cancer susceptibility genes, but within non-clear cell subtypes, they were more frequently mutated in RCC-specific genes. Notably, we also observed a significant association between metastasis and the presence of pathogenic variants in DNA repair genes BRCA1, BRCA2, and ATM. Next, to identify risk genes for RCC within the Canadian cohort, we compared gene burden between the RCC cohort and a control data set to see which genes showed to be significantly more mutated within the RCC cohort. We found that the CHEK2 and ATM genes showed a significant association to ccRCC, whereas the FH gene showed a significant association to non-ccRCC. And these results are really similar to those that were seen within the European cohort, which isn't really surprising considering the largely European ancestry of the Canadian population. We also wanted to look at differences in gene burden between published large cohorts from Canada, Europe, Japan, and the US to identify differences in risk genes between cohorts from various countries. And in this analysis, we found that the cohort from Japan was enriched for pathogenic variants in TP53, whereas all others were enriched for MITF and CHEK2. Additionally, the US cohort showed a greater burden of FH and BAP1 mutations. Unfortunately, a lack of information regarding ethnicity of patients didn't allow us to report on specific population-based genetic differences. However, our findings still bring new insights into the global differences in germline susceptibility to RCC. And one area that we propose that this is useful for is for refining gene lists for clinical genetic screening for RCC based on country and population-specific data. So, for example, the current Canadian guidelines for referral to genetic screening rely primarily on an early age of onset, the presence of bilateral or multifocal tumors, or a close family history of renal cancer. And we realized that within the 56 Canadian patients with germline pathogenic variants in our study, only 15 of them meet this criteria. This means that 73% of patients with identified pathogenic variants would not be eligible for genetic screening in Canada. And similar rates have been reported for the US and in the UK, which highlights the need to revise criteria to capture more patients that are affected by potentially actionable germline mutations. One example of this could be just increasing the age of onset criteria in Canada by 5 years, which would result in an additional 5 patients meeting the criteria. In addition to more inclusive guidelines for genetic screening, our results also indicated that expanding the current list of genes for screening may be necessary. Currently, BRCA1 and 2, CHEK2, and ATM are not typically included in genetic screening for renal cancer in Canada. Overall, this study represents the first large-scale study investigating germline susceptibility to Canada in the Canadian population, to RCC in the Canadian population. We identified key differences in risk genes globally and highlight how current referral criteria for genetic screening for renal cancer do not identify the majority of patients harboring these germline pathogenic variants. For individuals with a germline susceptibility to RCC, this can have implications for surgical and treatment decisions, as well as for disease surveillance and health management for carriers and their at-risk relatives. And lastly, of course, I'd like to acknowledge all of my collaborators, both at McGill and in Japan at RIKEN IMS, and my funding sources for their contributions. I'm happy to take any questions at the poster session next door. Thank you.
Great. Thank you. Okay, last but not least, LIGHTSPARK-013, randomized phase 2 study of 2 doses of belzutifan in patients with advanced clear cell RCC. Dr. Gattalia.
Hello. I'd like to thank the organizers for giving us this opportunity to present the results of LIGHTSPARK-013, randomized phase 2 study of 2 doses of belzutifan in patients with advanced clear cell RCC. So the learning objectives are: what is the appropriate dose of belzutifan, the first-in-class oral HIF-2 alpha inhibitor, to maximize efficacy and minimize toxicity? So constitutively active HIF-2 alpha is a key oncogenic driver in clear cell RCC. The first-in-class oral HIF-2 alpha inhibitor, belzutifan, is approved for treatment of von Hippel-Lindau disease-associated RCC, CNS hemangioblastomas, or pancreatic neuroendocrine tumors not requiring immediate surgery based on results of the phase 2 LIGHTSPARK-004 study. Belzutifan has also shown anti-tumor activity in patients previously treated advanced RCC in phase 1 LIGHTSPARK-013 study. In LIGHTSPARK-001, doses from 20 milligram to 240 milligram once daily were evaluated, but the maximum tolerated dose was not reached. 120 milligram once daily dose was selected as the recommended phase 2 dose based on totality of safety, PK, and PD data. The phase 2 LIGHTSPARK-013 study compared belzutifan 120 milligram with a 200 milligram dose for patients with advanced RCC that has progressed on prior anti-PD-1, PD-L1 therapy in order to evaluate the safety and efficacy of these 2 doses in a larger randomized trial. Here we present the safety and efficacy results from the 013 study after a median follow-up of 20.1 months. Here's the design. Key eligibility criteria included patients with advanced RCC that have received no more than 3 prior lines of treatment for advanced RCC and should have received at least 1 prior anti-PD-1, PD-L1 therapy. Patients were randomized in a 1-to-1 fashion to receive either belzutifan 200 milligram daily or 120 milligram daily. And the primary endpoints of the study were overall response rate for RECIST 1.1, and for the secondary endpoints included PFS and duration of response, OS, and safety. So 154 patients were randomly assigned to the 200 milligram and 120 milligram group. As you can see, 21 patients in the 200 milligram group and 18 patients in the 120 milligram group are still ongoing treatment, and progressive disease was the most common reason for discontinuing this treatment. The baseline characteristics between the 2 groups were fairly balanced. There were about 80% of patients in both groups with intermediate poor risk disease, and about 20% of patients in both groups had received 2 to 3 prior TKI regimens. As you can see, the overall response rate were very similar between the 2 groups, 23.1% in the 200 milligram dose and 23.7% in the 120 milligram dose. If you compare the best percentage change from baseline in target lesions between the 2 groups, about 65% and 68% patients in the 200 milligram and 120 milligram dosing, respectively, were seen, as you can see here, and very similar between the 2 groups. The overall response rate by subgroup analysis was also very similar regardless of the various characteristics, including the age, race, gender, geographic region, IMDC risk factors, and prior lines of therapy. Even the duration of response between the two groups was very similar. The progression-free survival between the two groups was also quite similar at 9.1 months in the 200 milligram dose and 7.3 months in the 120 milligram dose that were not really significant statistically. The overall survival has not been reached in the study, but as you can see in the curves, they look very similar. Now, the adverse effects summary, in both groups, the grade 3 to 5 AEs were about 65 to 70%, but any dosing that leads to dose modifications was higher in the 200 milligram dose compared to the 120 milligram dose, at 57.7% in the 200 milligram dose and 46% in their 120 milligram dose. And similarly, there was more treatment-related discontinuation due to AEs in the belzutifan 200 milligram dose compared to the 120 milligram dose. The side effect, including anemia, fatigue, and hypoxia, were the most common ones. And in general, they were quite similar between the two groups, but grade 3 for anemia was more common in the 200 milligram dose, indicated by the dark blue bars here, compared to in the belzutifan 120 milligram dose. So in conclusion, the efficacy of 200 milligram belzutifan was comparable to the recommended phase 2 dose of 120 milligram once daily. The overall response rates and the PFS and overall survival were very similar between the 200 milligram and 100 milligram belzutifan doses. The safety profiles of the two doses are generally similar and consistent with the known safety profile of belzutifan, but the 200 milligram dose was associated with a higher rate of overall dose modifications and drug discontinuation. These results, together with the results from the 005 study, continue to support 120 milligram once daily dose of belzutifan in patients with RCC. And the take-home message is essentially the same, that the results of the 013 study indicate that the 120 milligram belzutifan dose is appropriate for patients with clear cell RCC. Thank you for your attention.
Great. I think we need to stay on time, so we only have probably a few minutes for questions. As you guys are coming up, just want to remind you that there is a winner of the most aesthetic, most beautiful poster, and you can see that if you go to the poster hall. That's been voted upon, so that's a special award that we have. Do we have any questions from anybody? I see somebody coming up. Please.
Yes, thank you. I have a question for Monty. Did you look at whether those patients who responded after cabozantinib progression had initially responded to cabo? Because when we challenge patients with cabo, if they have responded, most of them will respond again. So my question is about those patients who responded to zanzalintinib.
Yeah, so, as we mentioned, out of those 4, responses that we saw in patients, with prior cabozantinib received, 3 of those patients had ultimately had progressive disease on cabozantinib. We're still kind of going back and trying to capture their previous responses to cabozantinib. So your point's very well taken. I think that's something we're going to look at in more detail.
Any other questions? I guess my one question was about the screening, and I think you made a great point that maybe the age needs to be raised. I mean, we were just talking, it's amazing how many patients you miss. Is that something that you guys are discussing in Canada? Is that something you sort of would recommend? And yeah, I'm curious what the audience actually thinks about that, if anybody has any thoughts on it.
So unfortunately, I don't have the power to change that. But one thing to note here is that the age is different in Canada than it is in the US. So in Canada, it's 45, and in the US, I believe it's 50. So, clinicians are discussing changes, but I don't think there's been any push for it yet.
All right. Oh, perfect.
Hey, Dan.
Hey.
My question is for Monty. I thought that was really exciting data, and I wasn't necessarily anticipating to see such high response rate in patients previously treated with Cabo. Did you guys do any digging in terms of how patients were doing initially on their first TKI before? Is this a very responsive population? I know that you showed that 1 to 3 lines of therapy, a good portion had liver and bone, but we keep seeing a lot of times pretty high numbers in these early smaller studies, sometimes again heavily responsive serial responding type of patients. Did you guys look into how their quality of responses were with Cabo initially, or do a little deeper dive, or just is this a really special new drug?
No, yeah. I mean, I think it's, a lot of the latter, frankly. If you go back to the presentation of data from the dose escalation cohort last year at ESMO, we have some nice sort of swimmer's plots that outline patients and their prior trajectories on various regimens. And you'll see there are lots of patients with short-term responses to TKI-IO combos, followed by monotherapy, followed by monotherapy, followed by monotherapy, and then a beautiful response to zanzalintinib. And I've had that experience clinically. There's something very unique about this drug. I have a 45-year-old patient who I've been treating for the past 3.5 years. And for the first 1.5 years or so, he really sort of zipped through a number of lines of systemic therapy. And he's been able to maintain therapy with zanzalintinib for 2+ years. So I think it's something quite, unique and potentially transformative.
Very promising.
Yeah.
Great. And goes along with the theme of this meeting, transformation, progress for patients. And we're perfectly out of time, so to stay on time, let's move on.